Usually when you think about getting a medical diagnosis, there is a certain expectation of, well, a mechanical precision. You break your arm, the x-ray shows a very obvious jagged white line, and the doctor just points at it and says, there it is.
Exactly. It's binary. Like, it's broken or it's not broken.
Right. And that is comforting. But, what if the era of wait-and-see medicine is completely dead? What if a routine standard photograph of your eye taken today could tell a doctor with terrifying accuracy that you will develop Alzheimer's a full decade before you ever forget a single name?
It sounds like science fiction, honestly, but that is exactly where the technology is standing right now.
Which is why you are here with us today.
Yeah.
Welcome to a massive rapid-fire deep dive. For you listening at home, we are staring down an intimidating stack of exactly 23 cutting-edge medical AI papers. And our mission is simple, but incredibly ambitious. We need to extract the ultimate cohesive picture of where the future of medicine is heading.
But there is a catch.
There is a really big catch. We are on the clock and aiming to land this plane in exactly 15 to 17 minutes, so buckle up.
Yeah, we have a very clear roadmap for this sprint. We are going to journey from how AI actually thinks, differentiating a chat box language from true medical logic. Then we will drop into the absolute chaos of the ICU to see how the technology handles missing data. From there, we will look at the superhuman vision revolutionizing radiology. And finally, we will explore how this tech is moving out of the hospital and directly into your home.
Okay, let's unpack this. We are starting with the brain of medical AI. I think, a lot of us assume that if an AI sounds like a seasoned physician, if it has a great bedside manner, it must be reasoning like one.
It is a very easy trap to fall into, and paper 2 tears that assumption completely apart.
Oh, really?
Yeah, so paper 2 introduces something called the VB score framework, and what it reveals is that just because an AI's answer is semantically similar to what you'd read in a medical textbook, well, that doesn't mean it is medically accurate for the specific patient. Even more critically, the paper highlights condition-based algorithmic discrimination. When they tested these models on public health topics, the AI's performance dropped by almost 14% on conditions that primarily affect older and minority populations.
Wow. So if I'm understanding this, are we basically treating standard language models like a smooth-talking medical student who, memorized the entire textbook but completely lacks actual clinical judgment?
Exactly. They are incredibly good at generating plausible sentences, but prompt engineering alone cannot fix their fundamental architectural inability to reason safely. They are guessing the next word, not diagnosing a human.
Okay, so how do we fix that? Because I'm looking at paper 16, which introduces a framework called the Bayesian Medical Belief Engine, or BMBE, but it uses the phrase deterministic Bayesian engine. What does that actually mean for you as a patient?
It essentially means separating the talking from the thinking. In paper 16, the large language model, the chatbot part, just acts as a sensor. It listens to what you are saying and parses the text. But it is not allowed to make the diagnosis. All the actual medical inference gets handed off to a deterministic Bayesian engine. Think of it like a strict mathematical flowchart of probabilities. It never lets the hallucination-prone AI actually make the life or death decision.
That makes so much sense. It's like having a receptionist take your symptoms, but a strict medical board actually reviews them. And speaking of strict rules, I see paper 12 targets clinical trials with something called LLM StructCore. It says it uses a zero LLM deterministic compiler to fill out medical forms. Why take the AI out of the final step entirely?
Because in a medical trial, a false positive isn't just a minor mistake. It ruins the entire data set. Filling out a case report form is like doing your taxes. You do not want a creative accountant guessing numbers.
Yeah, fair enough.
So paper 12 uses AI to gather the data, but relies on rigid, hard-coded rules for the final output, so there is zero room for creative AI guessing.
I love that. And paper 10 takes bypassing giant language models even further with HypEHR. This completely bypasses standard massive AI models for looking at electronic health records. Instead, it embeds patient visits into a hyperbolic space. I have to admit, I am completely lost on that term. What is a hyperbolic space?
Let's use an analogy. Imagine trying to draw the entire Earth on a perfectly flat piece of paper. The distances get warped, right?
Yeah, Greenland looks massive.
Exactly. Traditional AI tries to force complex medical history onto a flat map, which warps the relationships between diseases. Hyperbolic space gives the AI a 3D globe. It allows the AI to see the natural, branching, tree-like structure of medical data, knowing that asthma and a common cold are close together, but, miles away from a broken leg.
Oh, wow.
Yeah, and paper 10 proves you can get incredible efficiency using far less computing power just by giving the AI the right geometric shape to think within.
Giving it the right structure, that's brilliant. But perfect logic and 3D globes are great in a controlled theory. What happens when we take these models into the absolute messy reality of the ICU?
That is where the math hits the fan. In the ICU, data is rarely clean. It is irregularly sampled, it's chaotic, and machines get unplugged.
Right, which brings us to paper 1. Paper 1 tackles sepsis, which is a notoriously complex infection to catch early. The researchers built an AI simulation that explicitly models your physiological trajectory before the disease even hits.
Yes, it predicts how your vital signs will evolve over the next 4 to 24 hours, keeping those predictions strictly within physiologically plausible ranges.
But hold on, if you're trying to predict my heart rate for the next 24 hours, what do you do about the gaps? If I'm a patient in the ICU, I might be unhooked from a machine to go to the bathroom or get a scan. Doesn't the AI just make up fake data to fill those gaps?
Artificial imputation making up data is incredibly risky in medicine, and that is exactly what paper 15 addresses with 𝗂𝗵𝗆 for acute kidney injury.
How does it avoid making things up?
It uses a causal transformer. Instead of guessing what your blood pressure was during the 30 minutes you were unhooked, it establishes a clear, unbreakable chain of cause and effect from a historical physiological shock to your current risk prediction. It links the events that actually happened rather than fabricating the ones that didn't.
That's a huge distinction.
It is. What's fascinating here is how we are completely reframing the concept of missing data in the first place. Paper 7 and paper 23 tackle this brilliantly. In paper 7, the researchers prove that missing data isn't just a nuisance, it is actually a massive clue. They call it informative missingness.
Wait, let me make sure I'm getting this. The absence of data is actually data itself. So if I'm the patient lying in that ICU bed and my doctor decides not to order a blood test at 3 a.m., the doctor implicitly believes I am stable. That choice leaves a blank cell in my spreadsheet, but the AI looks at that blank cell and says, the doctor wasn't worried.
Exactly. It is a massively informative gap.
Yeah.
And paper 23 takes that insight further using autoregressive sequence modeling.
Autoregressive modeling, like what powers ChatGPT when it writes a sentence?
Precisely. Paper 23 treats a patient's entire hospital stay like completing a paragraph. It reads your clinical trajectory sequentially. If a piece of data suddenly drops out, the model doesn't panic and wildly change its diagnosis.
It just context clues it.
Yes, it fills in the blanks of the story based on the context of your entire stay, interpreting what that missing information actually means.
Okay, so we've got the logic down, and we know how it handles the messy timelines of the ICU. Let's pivot to visuals. Segment 3, how AI is rewriting the rules of superhuman sight in radiology and pathology.
We have to start with how the AI learns to actually see without bias, and paper 3 and paper 13 are foundational here.
So paper 3 mentions using reinforcement learning to refine disease classification. But wait, how does an AI teach itself to diagnose a lung without a human doctor constantly grading its homework?
Paper 3 uses something called group relative policy optimization. In very simple terms, it gives the AI a batch of different possible diagnoses for an image, and the AI compares them against each other, rewarding itself for the most logical, comprehensive answer. It forces the AI to refine its own accuracy independently.
That is wild.
Yeah.
But AI also has a notorious laziness problem, right?
Yeah.
It cheats if you let it. And that is what paper 13 is about.
Yes. Think of the AI like a very lazy detective. If an AI looks at thousands of X-rays and notices that a specific plastic chest tube is always present in patients with a collapsed lung, it might stop looking at the actual lung tissue.
Oh, wow.
The next time it sees a chest tube, it just blindly guesses collapsed lung. So paper 13 fixes this using dual causal inference. It basically puts blinders on the AI, forcing it to ignore those superficial shortcuts and untangled true causal effects. It makes the AI look at the actual biology.
Here's where it gets really interesting. Because once you force the AI to look at the biology, the accuracy is staggering. In paper 6, they point a vision transformer at adult brain tumors and achieve a 99.29% accuracy rate. But what I love is that it uses an attention rollout to provide heat maps so the human doctor can see the exact cluster of pixels the AI used to make its call.
It creates trust. You can actually see the AI's work.
But I have to push back a little here. A 99% accuracy rate on adults is amazing because, well, we have millions of adult brain scans. What happens when the data is incredibly scarce, like with pediatric patients?
That is a massive challenge, and it's exactly what paper 9 addresses. Pediatric brain tumors suffer from severe data scarcity, and visually the different subtypes look almost identical under a microscope. Paper 9 uses a contrastive fine-tuning framework.
Meaning what, exactly?
Imagine two different species of butterflies that look nearly identical. If you only have a few photos, you might struggle to tell them apart. Contrastive fine-tuning mathematically pushes those diagnostically confusing subtypes far apart in the AI's brain. It magnifies the tiny fine-grained distinctions so the AI can tell them apart confidently, even with very little training data.
Okay, so it can handle tiny details. But what about massive scale? I'm looking at paper 5, which deals with lung adenocarcinoma at the whole slide level. Instead of a doctor spending hours annotating every microscopic patch, the AI evaluates the entire slide's growth pattern at once.
Scale is the hurdle. And we see that same battle in paper 19, which tackles breast cancer classification from mammograms. Mammograms are huge, high-resolution images, and the abnormalities are microscopic. Standard AI models just get completely overwhelmed by the sheer number of pixels.
So how do they filter the noise?
Paper 19 uses an object detection model first, almost like a spotlight. It scans the massive image, dims the lights on all the healthy tissue, and forces the AI to focus all its computational power only on the specific regions of interest.
It's completely redefining how we find a needle in a haystack. But what if the tumor is actively trying to hide? Paper 11 focuses on pancreas tumors, which notoriously blend into the surrounding soft tissue. They created PanGuide 3D.
Right.
And before it even looks for a tumor, it generates a probabilistic 3D map of the pancreas. It essentially tells the AI, I know the exact borders of the pancreas, so do not falsely flag anything outside of this zone.
Context is everything. And for truly rare conditions, we have to talk about paper 21. It introduces mean shift density enhancement. This is brilliant because it only needs normal medical images to train.
Wait, it learns to find rare diseases by only looking at healthy people.
Precisely. It learns the exact mathematical distribution of perfectly normal human anatomy. When a new scan comes in, it simply computes how far the image deviates from that baseline of normal. It achieved near-perfect anomaly detection for things like brain tumors without needing to see thousands of examples of the tumors themselves. It just knows what doesn't belong.
That's incredible. And we're seeing this translated into dynamic, real-world workflows, too. Paper 4 introduces the DICE framework for capsule endoscopy. You swallow a pill camera, and it records tens of thousands of frames of your digestive tract. Most of it is totally normal, boring video. DICE acts like an intelligent fast-forward button, skipping the redundant parts and weaving together only the clinically meaningful frames to find sparse lesions.
And bringing it right to the surface level, Paper 17 presents the infection reasoner. This is a compact model designed to classify chronic wound infections just from a smartphone photograph.
Wow, just from a phone.
Yeah. Because wound appearances vary so wildly based on lighting, the model doesn't just blurt out a diagnosis. It actually generates a text-based, evidence-grounded rationale for why it thinks the wound is infected, giving the nurse or doctor immediate context.
Okay, take a breath. We are making incredible time. We have gone from pure logic to the chaos of the ICU to microscopic imaging. But for our final segment, we are bringing it home. How does all this high-tech reasoning integrate into broader society and into your daily life?
Well, none of these breakthroughs matter if the hospital systems can't actually talk to each other. The
Wow.
logistical hurdles are massive. Take Paper 18. It addresses a frustrating reality. An MRI from a machine in New York looks slightly different from an MRI taken in London just due to hardware differences.
Like different brands, different sensors.
Exactly. So Paper 18 developed HACA3 plus FARA, an algorithm that harmonizes MRI images across over 100 different scanners, effectively scrubbing the hardware bias out of the image so AI models can read them uniformly.
But then you run into the privacy issue, right? If hospitals are harmonizing data, how do they share it without leaking my personal health records?
That's where Paper 20 comes in. Paper 20 introduces the 𝗪𝗵𝗀.ai framework to solve this. It allows multiple hospitals or even banks and insurers to align their data and train AI models collaboratively using something called privacy-preserving multi-party set union.
Sounds complicated.
And for those wondering, a multi-party set union is basically like a secret ballot. It allows all these institutions to combine their insights and figure out what data they have in common without ever exposing the underlying private individual records to each other. It is a secure foundation that allows personalized AI to exist.
And that foundation brings the technology directly to your body. Look at Paper 8. They designed an agentic AI for at-home physiotherapy. Instead of watching a static, boring video to do your knee exercises, a multi-agent system uses your device's camera to watch your form.
Right.
It tracks your real-time pose and gives you instant verbal corrective feedback if you're doing it wrong.
It is literally a physical therapist living in your phone. And this shift toward opportunistic screening is happening everywhere. In Paper 14, they outline STRNet.
Oh, this one is fascinating. Let's say you go to the doctor because you tweaked your knee, and they take a routine grayscale X-ray. STRNet piggybacks on that exact same X-ray to do a highly accurate bone loss screening.
Yep.
It assesses your risk for osteopenia or osteoporosis without you ever needing to book a separate bone density scan.
If we connect this to the bigger picture, AI is transitioning from an acute intervention tool, something we only use when you are already sick in a hospital bed, to a silent, continuous guardian of your long-term health. Which brings us to our final and perhaps heaviest paper of the day, Paper 22.
The REVEAL framework. Now, I have to be honest, when I read this one, I was stunned. Hold on. You are telling me a basic photograph of my eye today can tell you if I will have dementia a decade from now. How is that biologically possible from just looking at the retina?
It comes down to the retina being an extension of the brain's neural tissue. Paper 22 combines a routine, non-invasive photograph of your retina's morphometry with your basic lifestyle risk factors.
Okay.
By aligning this multimodal data using a technique called group-aware contrastive learning, which essentially matches your eye's microscopic patterns against vast groups of historical data, this system can predict incident Alzheimer's disease. And it doesn't just predict it right before you show symptoms, it predicts it On average, 8 years before your first clinical diagnosis, up to 11 years in some cases.
So what does this all mean? We started with 23 papers and a ticking clock. And look at that. We are right inside our 15 to 17-minute window. We have traversed deterministic Bayesian engines, causal transformers in the ICU, superhuman anomaly detection in radiology, and AI physical therapists in your living room. The singular truth tying all 23 of these papers together is that the future of medicine isn't just about making human doctors faster.
No, not at all.
It is about predictive, hyper-personalized care that completely rethinks how we define data, treating a doctor's missing chart entry as a vital clue and a routine knee x-ray as a window into your entire skeletal system.
But it also leaves us with a profound, almost philosophical question for you to consider. If we go back to paper 22, if a simple, painless eye exam tomorrow morning can tell you with high certainty that you will develop Alzheimer's disease a full decade before your first symptom, do you actually want to know?
That is heavy.
It is. At what point does this hyper-awareness of our future health become its own kind of pathology? How will we mentally handle walking around in a world where our biological fate is mapped out 10 years in advance?
It turns out, clearing up the diagnostic muddy waters might actually give us a reflection we aren't entirely ready to look at. That is all the time we have for this deep dive. Thank you for sprinting through the future of medicine with us. We'll see you next time.